Very good evening, everybody. I hope you can hear my voice. If you could hear my voice and see the screen, just say yes. Unmute yourself and say yes. If you could hear my voice and see the screens properly, just unmute yourself and say yes. Everyone whomsoever here to acknowledge. If you could hear my voice and see the screen properly, say yes. Unmute yourself and say yes if you could hear my voice and see the screen properly.
Yes, sir.
Yes, sir.
So the screen is clear, I hope. And I want everyone present in the meeting to acknowledge faster that if you could hear my voice and see the screen properly, just say or type yes. We get it. So we'll wait for everybody to join and then we begin once everybody joins. Okay. So we shall we begin, people, or we wait for everybody to join? We can begin. And if the screen is visible to you guys, just say yes.
Yes.
Okay. We're gonna talk about the CSQs here, especially on the internal medicine area. Speaking about the CSQ, you have a variety of clinical based question, people. Conceptual knowledge is very much important in terms of your CSQs. So, how often you guys are familiar with the CSQ, conceptual based question? How often you guys are familiarized? Because like you have to know, because there are some diseases which follows the pattern. For example, I can say a person who comes with the left-sided chest pain, which is radiating to the jaw, and the severe profuse sweating to the ER, then obviously the diagnosis most corner two. The diagnosis most corner two. Patient with a chest pain radiating to the jaw with accompanied by profuse sweating and dizziness. What would be the end diagnosis, people? I can't see your comments or something. Just if you want to make it more interactive, the more we talk, the more we learn, as I say. If you want to learn more, just unmute yourself and say, talk more. So we could able to converse and we could able to generate a lot of, like we can share each other a lot of knowledge. So tell me, everybody. So let me cross check once whether my battery or not. I think I'm active, right? I think you guys can able to hear my voice and see the screen clearly, right? If you could hear my voice and see the screen clearly, say yes. Let me turn on. the devices. If you could hear my voice and see the screen, just unmute yourself and say yes. So I would rather go faster, faster, people.
Yes, sir.
Okay. So speaking about that, the first area of internal medicine aspect, shall we begin the class? Is it okay to begin? One more time, shall we begin the class? If you guys are ready, just say yes. Go ahead, unmute yourself and say yes, people, because here we're gonna talk a lot and lot and lot.
Yes, sir.
So we're gonna talk a lot. So first area we're gonna talk about here in the CSQ is your respiratory system. Speaking about the respiratory system, the topic of interest is the pneumonia here. The topic of interest is a pneumonia here. So first, how this class gonna work is like first I will explain you a little bit of concept, and then I will try to show you the question, so it will help you with that. I will run the background explanations for that question. So the first area we're gonna talk about in the respiratory system is the pneumonia. So speaking about the pneumonia, what is the pneumonia, people? What is pneumonia? Come on, faster. What is pneumonia?
Inflammation of lungs.
Inflammation of lung is or the infection of lung. Inflammation of lung or the infection of lung. So pneumonia is technically, pneumonia is technically the infection of your lung parenchyma. Infection of your lung parenchyma. Okay, so we got the infection. So how we get this pneumonia, people? How we get this pneumonia and what are the clinical features? Let me talk about directly. Clinical features. How does the pneumonia patient comes to you technically? How does the pneumonia patient comes to you technically? Okay. The pneumonia patients technically comes to you with the following clinical feature. Any patient with a fever and chills technically indicates patient is having an infection. And along with the fever and chills, he will have a productive cough. That productive cough may be any color, maybe rusty color or yellow color with the sputum. Productive cough with the sputum. That sputum may be any color. What color it may be? It could be a rusty, or it could be the yellow, or it could be the mucopurulent, or it could be the currant jelly, or anything it could be. Okay. So patient basically comes with a fever, chills, cough, and patient will have a pleuritic chest pain. They can't able to focus where the chest pain is, and along with that, he will breathe fast. So the patient may also have the tachypnea and pleuritic chest pain. Pleuritic chest pain. And apart from that, you will see what type of investigations you do on this patient's people. Technically, a patient walks into your OPD with a fever, chills, productive cough, and tachypnea with a pleuritic chest pain. What is the investigations you do on this patient people? Talk, talk, talk. Why are you guys are so hesitant in talking? The more you talk, the more you learn, as I said. Go ahead, people. Talk, talk, talk. I love to listen from your perspective also. So tell me, this patient has been walking into your clinic. So what is the first investigation you will do? because the entire CSQ pattern is based on this. That's why. Come on, guys. So the patients will have the fever, chills, cough, tachypnea, and pleuritic chest pain. Okay, once they come into your clinic, the first thing you have to do is run the CBC, and CBC shows what? Run the CBC, and CBC shows what? Come on, man. Elevated WBC. Okay, elevated WBC. And apart from that elevated WBC, you will also do what? Chest X-ray, sputum, gram stain and culture, and blood culture. Is my handwriting legible, and can you guys able to see the screen clearly? Is my handwriting legible, and can you able to understand these things?
Yes,
I want you
sir.
to know.
Yes, sir.
Yes? Okay, so my handwriting is okay for you guys. So if you want me to write it legibly, I will write it, no problem. Okay, so speaking about this, the patient is coming to you with a fever, productive cough, tachypnea, pleuritic chest pain, and the CBC showed elevated WBC and chest X-ray. So what type of things you will see on the chest X-ray, people? What type of things you will see on the chest X-ray?
Consolidation.
Very good. Consolidations. Next, what type of other things? So technically, we see three patterns in chest X-ray. We see three patterns of pneumonia in the chest X-ray. One is a lobar, another one is broncho, another one is interstitial. So we will see what are the common patterns you will see in the X-ray. We will see the lobar pneumonia, bronchopneumonia, and interstitial pneumonia. So what is a lobar pneumonia? As you said, consolidation. Consolidation is seen in the entire lobe of the lung. Consolidation in entire lobe. Very good. Okay, so you see the consolidation in the entire lobe, and apart from that, what are the other you will see? You will see the congestion, and apart from that, clinically you will see the red hepatization. Okay, these are the characteristic features of lobar pneumonia. Most common organisms causing a lobar pneumonia would be strep pneumo and club pneumo. Strep pneumo and club pneumo. Okay, very good. And the second is a bronchopneumonia. So what is a bronchopneumonia? You will see the patchy and the scattered consolidation. What you will see? Patchy and scattered consolidation. Okay, very good. Patchy and scattered consolidation often associated with, because it is a bronchioles, it is occurring in the bronchiole, it should be multifocal and it is also be bilateral. So the chest X-ray itself look a very cloudy. You can easily catch the bronchopneumonia in the X-ray. So what could be the common organism here? Staph aureus, Haemophilus, Pseudomonas, Legionella, all of them. Moraxella, Legionella, all of them are the common organisms which is causing a bronchopneumonia. In the X-ray, we will see the patchy scattered bilateral consolidation. While in the lobar, what type of consolidation we see? The only one particular lobe will be affected in there. Yes or no? Okay. Third one is an interstitial pneumonia. So speaking about this interstitial pneumonia, it is an atypical pneumonia. You will see the interstitial infiltrates. You will see the interstitial infiltrate on the chest X-ray. Okay, mostly it is caused by the bacteria or virus. Okay, so there are variety of interstitial pneumonia or atypical pneumonia. The most common organism for atypical pneumonia is, what was that? Mycoplasma. Okay, then chlamydia, then we have a viral pneumonias like CMV, RSV, influenza, Coxiella, all of them causes atypical pneumonia. So pneumonia is caused by only the organism, bacteria or virus. The other organisms or other pneumonia, is there any other type of pneumonia? Is there any other type of pneumonia? We have aspirational pneumonia. We have the aspirational pneumonia, which is due to the alcoholics and comatose patient. For example, I tell you, we had one patient around like 6 months ago. The patient is a stroke patient and typically went into coma. Okay, he couldn't able to recall, or he is a bedridden and he went to coma totally. Okay, all we have done was a Riles tube. Okay, we have injected the NG tube for the TPM. Okay, sorry, we have injected the Riles tube for the feeding. Okay, one day, what happened? A nurse accidentally pulled out that the Riles tube. And what is the most common risk when we try to reinsert that Riles tube? What is the most common risk associated with them? Fast, fast. What is the most common? The patient is a comatose. He is in the Riles tube. Accidentally, the Riles tube was pulled out. Okay, I am trying to reinsert the Riles tube. What is the most common risk I may face? I may have a chance to insert into where? While reinserting, I may have the chance to insert into where? Trachea. Come on. And since this is a yearly aspirated Riles tube, it have the food particles, so the food particle can go into the lungs and causes aspirational pneumonia. Why? Because there is a anaerobic bacteria in the oropharynx that was colonized over the Riles tube, like Bacteroides, Fusobacterium, Peptococcus. So this aspiration pneumonia typically results in the right lower lobe abscess. Okay, right? Lower lobe abscess. Let me go to the question, people, directly. Okay, now tell me here the case. Can somebody read the case for me? Can somebody read the case for me? Faster, if you could see the screen. Can somebody read the case for me? Faster, faster, people. We have a lot to discuss, so just move it faster. Come on, quick, 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 unmute yourself and read the case. Just read the screen, no problem. Come on, man. Is the screen visible to you guys?
Yes, sir. Yes, visible.
Yeah, go ahead, read it.
In the hospital attendant presented to clinic with few hotness of breath. She had similar symptoms twice in the last 2 months. On X-ray, there was a homogeneous right middle lobe consolidations with prominent oblique
Go ahead.
fissure.
Yes, prominent
What
oblique
is
fissure is there, homogeneous right middle lobe consolidation is there, and then she has a symptoms for past 2 months. How many days she has a symptom? She has a symptoms for? No, she has a symptom twice in the last 2 months. That is, it is recurrent. Okay, that is, it is recurrent. The first thing She is a hospital attendant. She is a hospital attendant. Okay. Second thing, fever, shortness of breath with the homogeneous right middle lobe
Homogeneous.
consolidation and with the prominent oblique fissure. This was the clues we have here. Yes or no? So out of this clues, so the first question here is, what is your probable diagnosis? Pneumonia is the probable diagnosis. Yes or no? So when it comes to the
Hospital
pneumonia,
appointment.
atypical pneumonia will be ruled out here. Why? It is not a atypical pneumonia or interstitial pneumonia, because we studied the X-ray patterns of the three pneumonia. What are the three types of three X-ray patterns we have studied now? Lobar. Go ahead. Lobar, bronchial, and
Lobar, bone, and interstitial.
bronchial and interstitial. Interstitial pneumonia is a atypical pneumonia. So we ruled out this atypical pneumonia option. What are the other three things? Hospital acquired pneumonia, healthcare associated pneumonia, and community acquired pneumonia, if I'm right. So talking about this hospital acquired pneumonia, the patient is a hospital attendant, but the patient is not hospitalized. So shall we fit in the hospital acquired pneumonia? Shall we fit in the hospital acquired pneumonia?
No.
No.
No. So we will remove the hospital acquired pneumonia also. So what are the two options which was very, very difficult options that we are left out with is number one is a healthcare associated pneumonia and number two is a community acquired pneumonia. So here comes the real issue, people, because though those two are fitting in the criteria, yes or no? Community acquired pneumonia also fitting in the criteria, and healthcare associated pneumonia also fitting in the criteria. Okay. So why the community acquired pneumonia is outrun by the hospital acquired pneumonia? Because of the other features that they had mentioned here. What is the similar symptoms twice in the last 2 months with the hospital attendant history? So she is a hospital attendant and she has a symptoms twice in the last 2 months. That is a recurrent. So this technically goes in and fit in the definition of the hospital healthcare acquired or healthcare associated pneumonia. So HCAP, if we are talking about, so typically they have given the definition here. So what is that? Infection occurring within the 90 days of a 2-day or a longer hospitalization. That's what the book says. Yes or no? So this is the healthcare associated pneumonia. So we done with the diagnosis here. So now we move on to the next one. So what are the which of the following is responsible here? I told you the X-ray is a consolidated lobar consolidation. When the lobar consolidation is happening, what are the two common organisms that ends up here? I told you what are the two common, which is organism which ends up in the lobar pneumonia?
Klebsiella.
Streptococcus pneumonia and
Streptococcus
Klebsiella.
pneumoniae and Klebsiella pneumoniae. Very good. Streptococcus pneumoniae and Klebsiella pneumoniae. So here we have both in the option. Pneumococci is also there and Klebsiella is also there. But what makes the answer here? So first thing, pneumococci is the most common organism causing a Klebsiella pneumonia. Okay, most common organism causing a pneumococci is the most common organism causing a community acquired pneumonia. Very sorry, my bad. Community acquired pneumonia. Okay, and Klebsiella is the most common organism in the middle-aged person or old people or hospitalized person or alcoholic or healthcare worker or diabetic. So this is the most common organism, especially in the middle-aged person, old people, hospitalized person, healthcare, and diabetic. All of them will have the higher chances of getting or developing the Klebsiella pneumonia. Okay. So here, which one is fitting the options? Here, which one is fitting the options out of these two?
Klebsiella.
He's a hospital attendant. Yeah, Klebsiella is the fitting option here. And remember, what is the type of sputum you will see in the Klebsiella pneumoniae? What is the other name of the Klebsiella pneumonia? Little curious. Microbiology, not my division, but I'm a little bit curious. What is the other name of Klebsiella pneumoniae? The pneumonia caused by Klebsiella pneumoniae. How do we name them? The scientist who named it. We call that as Friedlander pneumonia. Okay. Because Friedlander is a scientist who identified the organism which is causing the pneumonia. So technically, I wanted to share you one of the case which we have had around like 8 or 9 months ago. Okay, so what happened was the guy is a VIP guy. Okay, so you know when the VIP walks in the hospital, what are the nonsenses we get? Everybody comes and visiting him. Yes or no? Am I right
Yes,
or
sir.
wrong? Everybody will
Yes.
comes and visiting him.
Visiting.
Okay, so what happened was this guy was admitted for the craniotomy. Okay, especially for the craniotomy. And he was admitted for the craniotomy, and because he was a VIP, he was enjoying all the benefits. And post craniotomy, he had to be ICU isolated for at least 7 to 14 days on the ICU observation. Okay, since he is a VIP, what he did, not him, the surrounding person, what they have told the management that they have to be shifted to the specialized room, and he will be taken care in the specialized room. So ICU care was skipped. Okay, and when he was transferred to the specialized room, what are the higher chances? In ICU we restrict the movement of the attendants, but in the specialized room, can we able to restrict the movement of the attendant? Can we able to restrict the movement of the attendant? No, right? So a
No,
lot
sir.
of people are visiting him. So third day, he developed a severe cough with a currant jelly sputum. What is the characteristic finding here? Because the sputum was so copious, so yellow and reddish, that when we are inserting the suction tube, all it was coming was a red, and it was a thickened one. So we call that sputum technically as a currant jelly sputum or gelatinous sputum. Gelatinous sputum is a characteristic feature of. Now I come here. Gelatinous sputum is a characteristic feature of.
Pseudomonas.
Come on, shoot the answer.
Pseudomonas. Current jelly, Pseudomonas.
No, man. Currant jelly is what? Klebsiella. Why I have to mention this currant jelly sputum here? Because here the organism which is responsible is the Klebsiella. So patient developed the currant jelly sputum. So we got that Klebsiella. Okay, next. When the patient is having the pneumonia, all of the following are true auscultatory findings except is the low intensity sound. All the other things will come, which is a pretty straight question. Okay, bronchial breath sounds are low intensity. Okay, now for the diagnosis of pneumonia, the antigen can be obtained either from urine or sputum. This hold falls in the case of what type of pneumonia? Pneumococcal, mycoplasma, staphylococcal, and viral pneumonia. So what could be the answer here, people? We have 4 options here. Pneumococcal here, mycoplasma here, and then staphylococcal here, and then viral pneumonia here. So most, as I told you, when it comes for the diagnosis, we do the CBC. CBC shows a elevated WBC, and X-ray pattern. X-ray follows the 3 patterns. What are they? Lobar, broncho, and interstitial. So this followed the lobar, and lobar it could be streptococcus or Klebsiella. Here it is a hospital attendant with a fever and shortness of breath, and here with this right middle lobe consolidation with the prominent oblique fissure goes for the Klebsiella, which is a Friedlander pneumonia. So we removed that Friedlander pneumonia. Now going for the diagnosis, apart from that, we will do the blood culture or sputum culture or urine. We have to take the antigen of the organism. So apart from that, the type of pneumonia which has been mentioned here, one does not follow this typical pattern. What was that? Viral pneumonia, because that is a typical one. Pneumococcal, we do the culture. Staphylococcal, we do the culture because it follows the golden yellow colony. Yes or no? Which one follows the golden yellow colony? Come on, man. You guys answers me, then I will give you more information. If you guys remain quiet, I focus on the question itself. You guys want to get a more information, right? Okay. Staphylococcal will form the golden yellow colony. But here, everything goes in the culture except viral pneumonia. Because viral pneumonia, you have to get the isolation of the viral. Okay, so viral particles should be isolated and examined. So for example, CMV pneumonia. So CMV pneumonia is the most common pneumonia occur in the immunocompromised individual with the CD count of less than how much? Fast. CMV pneumonia is the pneumonia which occurs in the HIV patient or immunocompromised patient, especially with the CD count of less than 50. Keep that in the MCQ. It's a 50. So, okay. So, the pneumonia like a CMV pneumonia or the other pneumonia, you have to take a isolation of the viral particle by, or you have to run the RT-PCR or PCR. Okay, PCR of the viral particle. So, culture is not possible with the viral pneumonia. So, here you got the answers, people. So here it is a viral pneumonia, and here the bronchial breath sounds are low intensity, Klebsiella with a healthcare associated pneumonia. So we have dealt with the one case of pneumonia here. So any patients walking with the pneumonia, any patient walking with the fever, chills, with the productive cough, what is the first thing you will do? What is the first thing you will do?
Chest X-ray, CBC.
Very good. Chest X-ray, CBC, blood culture, LFT, RFT, and then urine culture. And then you have to do the sputum culture. Okay, all of the things you have done. All of the things you have done. So automatically, what will be the next thing? What will be the next thing? Whatever the organism grows, we treat, sir. Why are we taking attention, right? Anyways, it was nice. So we'll go on to the next question of the pneumonia. So the next question of the pneumonia again. So somebody can read the question, please. Can somebody read the question? Fast, people.
A patient with a diagnosis of lower pneumonia has been admitted in ICU for last 12 days. Today, one of the attending sister developed fever with cough. On evaluation, she is found to have a lower pneumonia too. What is the diagnosis?
Okay.
Nasopneumonia
The case was, very thank you, doctor. Sorry for interrupting you. Very sorry. You go ahead. Go ahead, doctor. Sorry. Sorry for interrupting you. Read the further question. Thank you. Yes. Okay. Anyway, so here the question here is confirmed here itself. They didn't trouble you with anything. What they have given you? What type of pneumonia? Straight from the textbook. What type of pneumonia? Fast,
Healthcare
people.
associated pneumonia.
It's a lobar pneumonia. Yes or no? Lobar pneumonia of a patient in ICU and the attending sister have developed a fever and cough. And she also got a lobar pneumonia. It might be the same organism. So he got the fever, cough, pneumonia, hospital worker. What type of pneumonia here it is? Healthcare associated pneumonia. Healthcare associated pneumonia, because she's a healthcare worker. And yeah, she's a healthcare worker and she is in the hospital and she develops a pneumonia. Okay, but here the problem here is we have a two organism which causes a lobar pneumonia. What are they? We typically have the two common ones which develops a lobar pneumonia. What are they? Go ahead, ma'am.
Staphylococcus.
I told you when I was teaching a lobar pneumonia, there are two organisms which result two most common organisms which causes lobar pneumonia. What are they? One is a Streptococcus, another one is a Klebsiella. Strep pneumo and club pneumo. Previously, what the question we have seen, that was a club pneumo. Now here we don't see the option of the club pneumo here, but if there is a club pneumo is the most common one. But here we don't see the club pneumo as option. So what is the most appropriate option we can choose here?
Streptococcus pneumonia.
Very good. Streptococcus pneumonia is the option which we chooses here. Okay. Speaking about the Streptococcus pneumonia. So we have a variety of organism here. So Streptococcus pneumonia is a what type of organism? Gram positive or gram negative? Cocci or bacilli? Cartilage positive or coagulase positive?
Gram negative.
Gram positive.
It's a gram positive cocci. Okay, gram positive cocci. So you know the algorithm of the gram positive cocci? Gram positive cocci could be Streptococcus or Staphylococcus. So we do the catalase test. Okay, when the catalase is positive, then it is Staphylococcus. Catalase is negative, then it is a Streptococcus. Okay, when it goes for the catalase negative Streptococcus, we have a three types of hemolysis. One is a alpha, beta, gamma. Okay, alpha hemolytic Streptococcus is so called as, what do we call that? Streptococcus pneumonia. Streptococcus pneumonia is a alpha hemolytic catalase negative gram positive cocci. Okay, now let me come into this pneumonia, people. So speaking about this pneumonia, which we have been discussing here. So what type of pneumonia is the most common pneumonia that we have done about that Streptococcus or Klebsiella pneumonia? So we have done with the cases of Klebsiella pneumonia. While Streptococcus we will see. So speaking about the Streptococcus is a gram-positive cocci, as I said. So what is the drug of choice for the above condition? What is the drug of choice for the above condition? So most of the pneumonia is caused by the Streptococcus, and management is totally based upon the curb score. You know the curb score? What is the curb score? CORB, curb 65 score. That determines whether the patient has to be admitted or inpatient or home treatment or ICU. You know, when the pneumonia comes as a OPD, pneumonia comes as a ICU patient, pneumonia comes as a IPD. So how do we decide that whether the patient to be admitted in the inpatient or ICU, or he can be discharged with the home antibiotics based on the curb 65 criteria. What are the components of curb 65 criteria, people? I'm so sorry, I'm talking more and more informations to you. It takes very hard to progress, but I can understand, but I will try to cut down most of the top and rely on the questions. So, but just tell me, what is this curb 65? Curb 65 is a component which determines whether the patient is to be admitted or to be shifted to ICU or to be shifted to the or discharged and followed up in the OPD. What are the components of the curb 65, people? Any idea? If not, say no, no problem. I will say it. Nobody knows everything, right? Yeah, go ahead. What is this curb 65? Confusion. C stands for confusion.
Confusion.
U stands for urea more than 7.
Urea.
Okay, urea more than 7. And R stands for respiratory rate of more than 30. And BP
30, yeah.
should be, systolic should be less than 90 or diastolic should be less than 60. Okay, less
60.
than 90/60. Okay, and 65 is the age more than 65 years old. Okay, so based upon that, if the curve 65 is 0 to 1, then the patient to be discharged. If curve 65 is 2, patient should be admitted in IPD. If the curve 65 is more than 3 to 5, then the patient should be admitted in ICU. Okay, because the mortality risk would be more than 42. But if the patient have a score of 5, then the mortality rise would become 60%, around 60, 57 or 60. Okay, but now speaking about this pneumonia, management. So if the patient is curb 0 to 1, we can give amoxicillin 500 TDS. Okay, if the patient have a curb 65 of 0 to 1, we can give amoxicillin 500 TDS. If the patient is having a curb score of 2, then we have to go ahead with the amoxicillin 1 gram of TDS and clarithromycin 500 BID. Okay, and curb is 3 to 5. We have to give co-amoxiclav 1.2 IV TDS plus clarithro 500 IV BD. So here we have amoxiclav, azithro, levofloxacin. We can give any of this. But as per the BTS, I follow the BTS guidelines. So as per the BTS guidelines, when curb is 0 to 1, you have to treat it with amoxicillin 500 TDS oral, and curb 2 treated with amoxicillin 1 gram, 500 to 1 gram plus clarithro 500, and curb 3 to 5 co-amoxiclav 1.2 plus clarithro 500 IVB. Okay, so here we based on the option here, we can choose any of this depending on the cultural growth. Okay, next, which organism is associated with secondary infection in influenza? So secondary infection means super infection. One infection has already occurred, so the another infection which occurs as a super infection. So what organism commonly causes super infection? That is one typical common organism, which is your, what is that? One typical organism which causes your super infection. What was that? Fast, people. Staphylococcus is the answer here. And which one of the causal factor for lipid pneumonia? Speaking about the lipid pneumonia causal factor. So lipid pneumonia is a different one, people. Lipid pneumonia is a different one because we have the aspiration of the lipid containing material which causes a exogenous lipoid pneumonia or lipid pneumonia. Okay, here we have the options here: gastric acid, water, kerosene, paraffin. What is a lipid pneumonia? I told you, aspiration of the lipid containing material which causes a pneumonia. So here water, so lipid containing material is not there, so eliminated. So what are the other three options which we can conclude with? Kerosene, paraffin, gastric acid. And gastric acid is a HCl. Does it contains any lipid? It contains only H plus and Cl minus. So we will remove the gastric acid also. So we ended up with the two options. One is a kerosene, another one is a paraffin. Paraffin is a mineral oil which contains a lipid. So paraffin is a causal factor for lipid pneumonia or lipoid aspirational pneumonia, while kerosene causes chemical pneumonitis. Okay, not pneumonia. It causes inflammation of a lungs secondary to the chemical. Okay, so whenever the patient drunk the kerosene and comes to you, obviously you have to expect the chemical pneumonitis. So here, what is the answer here, people? Here, what is the answer?
It's paraffin.
Very good, paraffin. Paraffin is the answer here. So we conclude the case. So what is the diagnosis here? Healthcare associated pneumonia is a diagnosis here. And what is the healthcare associated pneumonia as a diagnosis here? And what is the common organism here? It should be Klebsiella, but not there. So Streptococcus pneumoniae. And what is the drug of choice? Any of the above. And what organism causes superinfection? Staphylococcus. And what is the causal factor for lipid pneumonia here? Paraffin. Okay. Clear, people? Shall I move on to the next area?
Yes, sir.
Okay. I move on to the acute exacerbation of COPD here. So 70-year-old male with a known case of COPD presented with shortness of breath and altered sensorium. Shortness of breath, altered sensorium. On presentation, patient's respiratory rate was 32 breaths per minute, heart rate was 88, BP was 130/90, oxygen saturation was 96. So the patient, what is the area here? The patient is sick or a patient is okay? Patient is tachypneic and patient saturation is 96, altered sensorium with shortness of breath. So what is this? The patient is sick, really sick, because the patient is having a hypercapnia here. So hypercapnia, the cause of the altered sensorium here is mainly due to the CO2 retention, because patient is having a type 2 respiratory failure here, people. Patient is having a type 2 respiratory failure. So what are the type 1 and type 2 respiratory failure? Can somebody tell me? What are the type 1 and the type 2 respiratory failure? Fast, fast, fast. What is a type 1 respiratory failure and what is a type 2 respiratory failure?
Carbon dioxide retention.
Okay. And type 1? Go ahead, man. Simply say me. In a normal English, you can simply explain me. What is a type 1 and a type 2 respiratory failure? Here, what type of respiratory failure happened? Here, patient is having a type 2 respiratory failure. What is the type 1 and what is it? How does the type 1 respiratory failure occurs and how does the type 2 respiratory failure occurs? When there is a perfusion defect or V by Q mismatch, you will see the type 1 respiratory failure, which is a hypoxemic respiratory failure. Okay, while type 2 is a ventilator failure. Okay, when you have a ventilation perfusion defect, no. So perfusion defect associated with the type 1 and ventilation associated with the type 2. Okay, so mostly type 2 resulted in the CO2 retention. So that's why we will see the hypercapnic, hypercarbic respiratory failure here. So here the patient is a COPD guy. So COPD patient technically develops type 2 respiratory failure. While type 1 respiratory failure is most often developed by the this infection guys, pneumonia, ARDS, pulmonary edema with the pulmonary embolism, all these people will develop a type 1, while COPD, asthma, drug overdose, and any chest wall abnormalities, they will result in the type 2 respiratory failure. They will result in the type 2 respiratory failure. That's the difference between the 1. So any patient with the asthma with the normal or low PCO2 is coming to you, then it is a life-threatening asthma. The patient may develop a respiratory failure. You have to remember, any patient with the COPD with the tachypnea and oxygen saturation is falling out, then it is due to the type 2 respiratory failure impending is happening here. So here, the cause of the altered sensorium is due to CO2 retention. So CO2 retention here is mentioned as hypercarbia. Okay, what is a hypoxia? What is hypoxia, people? Fast.
Lack of oxygen.
Very
Lack
good.
of
Somebody. Lack of
oxygen.
oxygen. Where you lack of oxygen? There is a difference between hypoxia and hypoxemia. What is hypoxia and what is hypoxemia? That's what fast.
Arterial blood hypoxemia.
Very good.
Tissue perfusion, the decrease in oxygen tissue perfusion is hypoxia.
Very good, doctor. So say it out once again louder so everybody can understand.
Hypoxia is due to decrease in oxygen concentration to the tissue, and in arterial
Yes.
blood, decrease in oxygen is hypoxemia.
Very good. In a simple words, we can say lack of oxygen in the blood, it is hypoxemia. Like hyponatremia, hypokalemia, hypoxemia, lack of oxygen in the blood. While hypoxia is, as you said, it is a lack of oxygen perfusion in the tissue, or lack of tissue oxygen perfusion is hypoxia. While respiratory acidosis can trigger the H+, but it doesn't cause the altered sensorium that much. And hypocarbia is lack of carbon dioxide, while hypercarbia is accumulation of the carbon dioxide. So here the cause of the altered sensorium is due to hypercarbia. So now I will ask you, whenever the patient is coming to you with the COPD, the doctor, whenever the patient is coming to you with the COPD, we have a variety of management, and we have the variety of clinical features, and we have the variety of oxygen options and all. So first, let me explain the COPD stable management. When the patient is stable, what is the generally you will advise this patient? Okay, we have one more option here. No, investigation. What you will investigation? You will see send for this guy in the emergency room. That is obviously ABG. Because chest X-ray, obviously we know he is a COPD. Nothing else will come out of that. And CBC, yeah, obviously he will have the eosinophils or other options which are altered. So we know that. What is the new? How can we acquire this new finding? Through the ABG. Respiratory acidosis will be visible on the ABG. Okay, so the investigation you will send for this case in the emergency room is ABG is the first option. Okay, next, the patient is admitted and ventilation should be done with. We have 4 options here. Can someone read out the options, please? The patient is admitted and ventilation should be done with. What are the 4 options we have? Endotracheal intubation and IPPV. Yeah. Endotracheal intubation and PSIMV, non-invasive PPV, and high flow oxygen and mask. So COPD management in terms of emergency, I will directly skip because it is a biggest topic. I don't want to talk about the LTOT and all those things, but I will talk about the oxygen therapy in the patients who are critically ill. Okay. So we follow the step of things. So what are the steps we follow? First, we will give him the oxygen in the nasal prongs. And then once the oxygen is not maintained, we will give him in the normal mask. Then we will give him in the non-rebreathable mask. Then we go for the NIV. Then we go for the intubated ventilation. Okay, so here, what are the oxygen target in the COPD patients? Especially with the hypercapnia COPD patients, because here the patient is having a hypercapnia. Yeah,
88 to
very good.
92%.
Very good. The patient who is at the risk of hypercapnia, the target oxygen saturation is 88 to 92%. Yes or no? And any patient with the COPD, remember high flow oxygen is contraindicated. Most of the doctors makes that mistake. They will turn out the oxygen completely and they will keep it. High flow oxygen is contraindicated in COPD. Why?
CO2 narcosis can be occurred.
CO2 narcosis, yes. Very good. How does the CO2 narcosis is happening?
Due to carbon dioxide retention.
I can say carbon dioxide retention, but when you are giving a high flow oxygen, when the patient is suffering from both hypoxia and hypercapnia, no, the respiratory center was solely stimulated by the hypoxia. Okay. So when the patient was supplied with the high oxygen, the patient will lack his respiratory effort. Okay, when the respiratory effort is lost, already the lungs have been damaged, respiratory effort is also lost, the condition will drive him to worsen because he will be dependent completely. When he was especially given with the high concentrated oxygen, this will deprive him of this hypoxic drive. Okay, anyway, so speaking about the management, when it comes to the management, use a 28% Venturi mask at 4 liter per minute with the oxygen saturation maintenance of 88 to 92. That was we always say. If the PCO2 is normal, then the oxygen saturation should be target oxygen saturation in COPD with the normal PCO2. Here high PCO2 is there. What about the normal PCO2? (92 to? Go ahead. You have given me
95.
correct answer there. 94, 92 to 98 we give technically, but average we will maintain at 95 to 96, as you said. Okay, now we go for this patient. The answer here is a NIV, which is a non-invasive PPV. So NIV is the treatment of choice for persistent hypercapnic ventilation failure despite the optimal medical therapy. This is a sentence which was exactly given in the Harrison. What was that? NIV is a treatment of choice for persistent hypercapnic ventilation failure despite the optimal medical therapy. Okay. So when you should consider NIV in this kind of patient? When? Within the first 60 minutes of hospital arrival. You should know. When? Within the first 60 minutes of hospital arrival. Then let's talk about non-invasive ventilation key indication. Any patient with the COPD with the respiratory acidosis, especially with the pH between 7.25 to 35. You want me to write it here? You want me to write it here, the key indications of a NIV?
Yes, sir.
Any patient with the COPD and ABG showed a pH of 7.25 to 35. 7.25 to 7.35. Okay. And type 2 respiratory failure. Type 2 respiratory failure, especially due to neuromuscular disease or OSA or something. Then cardiogenic pulmonary edema. Cardiogenic pulmonary edema. And weaning from tracheal intubation as a step down. Weaning from tracheal intubation. Intubation are the key indication. Out of these key indications, out of the option mentioned here, we don't intubate directly because the patient is okay. So both endotracheal intubation has been removed. Yes or no? We don't do the surgery directly. We don't need to cut off his throat. So both endotracheal option is gone. What are the option we left out with? Non-invasive PPV and high flow oxygen mask. High flow oxygen mask is contraindicated. Why? I told you. And NIV is the one option we left out with. Anyway, speaking about the indications, what are the indications? Can somebody read out the indications? Can somebody read out the indications here? Faster, so I will move on to the next area. Fast.
pH 7.25 to 7.35, type 2 respiratory
Very
failure,
good.
cardiogenic pulmonary edema, weaning from tracheal intubation.
Very good. So you understood the things. Shall I move on to the next? Okay. The next area here we have is a cor pulmonale. And a cor pulmonale, if you are speaking here, can somebody read the question here? Can somebody read the question here?
60 years old chronic smoker presented to the OPD with the chief complaint of breathlessness and productive cough. The patient was in respiratory distress. On examination, there was a presence of bilateral diffuse rhonchi, prominent S2 with pansystolic murmur, and bilateral lower edema was present along with hepatomegaly. Chest X-ray revealed hyperinflated lungs with cylindrical cardiac silhouette. The ECG showed deep Q waves and ST segment changes in the inferior lead. What is the diagnosis based upon the given history, examination, and investigation?
Okay. So we have a 4 option here: congestive heart failure, COPD, left heart failure, and cor pulmonale. Okay, speaking about his breathlessness, productive cough. Obviously, it is passing on to lung disease. Rhonchi is there, murmur is there, so lung and heart. Edema is there, hepatomegaly is there. So liver, lung, heart, and similarly we take a X-ray. X-ray showed a hyperinflated lungs with a cylindrical cardiac silhouette. And ECG showed deep Q waves with the ST changes in the inferior lead. Okay, technically it is a case of multisystem with the heart, with the lung, and with the liver. So speaking of this heart, lung, and the liver, I rather go for the cor pulmonale here as the option. Okay, sir, why we don't reject this with the left heart failure, or we can't able to go with the congestive heart failure and all. Okay. So the cor pulmonale features, let's see with the cor pulmonale features. Raised JVP, okay, loud P2, and parasternal heave, peripheral edema are the cardinal features of this cor pulmonale. Cor pulmonale is due to the right side of the heart failure, secondary to the lung infections or lung condition, I rather say. So here comes what makes it different from the left heart failure and what makes it different from the congestive heart failure. In congestive heart failure, you will not see any abnormal in the cardiac silhouette. You will see the other features like a fluid overload status with a flash pulmonary edema and all those things. Okay. And apart from that, so it is technically indicating the structural heart defect with the hyperinflated lung. And you will also see the prominent S2 pansystolic murmur, which is associated with the tricuspid regurgitation. Tricuspid regurgitation, diffuse rhonchi, productive cough, lower edema with hyperinflated lungs, and hepatomegaly. Hepatomegaly indicates it's involving in the right side of the heart. Okay, when it comes in the right side of the heart, obviously we will go for this. Cor pulmonale. Here the answer is a cor pulmonale. Here the pansystolic murmur is due to, I already told you, what is that? Tricuspid regurgitation. What is the cause of the hepatomegaly here? The cause of the hepatomegaly is due to the
Infiltration.
Right heart failure. Okay, why there is a hepatomegaly due to the right heart failure?
Due to decreased venous return.
Yes, venous return is one of the option. But you know, when the ventricles has been completed or completely full, it is unable to pump the blood to them. So obviously it will go to the backflash, backrush or backflash we used to call it. So when it transmit back, the first vein it reaches is a hepatic vein. Okay, when it reaches the hepatic vein, it causes a hepatic congestion that results in the congestive hepatopathy that progress into the hepatomegaly. Okay, that progress into the hepatomegaly. Which of the following medication is of no necessity in this condition? Okay, here we have all the things: anticoagulant, inotropes, diuretics, and oxygen here. So speaking about the medications for the cor pulmonale with the right heart failure, considering the option here, oxygen, obviously patient will desaturate, so we need the oxygen. Obviously patient desaturates, so we need that oxygen. So oxygen we remove it. Other drugs, anticoagulant is there, inotrope is there, diuretic is there. So because of the congestion, the patient unable to pump the blood to the systemic circulation. So obviously patient will develop a low BP. So when there is a low BP, you have to use the inotropes for that, and diuretics, you have to remove the fluid congestion through the kidney. So all three are important except the anticoagulant, because anticoagulant play no role here. Okay. Apart from that, you will also, there are certain drugs which are also not recommended by the NICE. One are the ACEIs, CCBs, and alpha blockers. Most people, maybe you get in the exam as another options. And what further investigations would you like to send to confirm the diagnosis? Obviously, transthoracic echo. We do the echo to quantify the fluid level in the goddamn right ventricle. Yes or no? So what is the test here? What is the diagnosis? What is the further investigation here? Echo is the further investigation here to quantify the congestion. Okay. So done with this. So diagnosis is cor pulmonale. Pansystolic murmur is due to the tricuspid regurgitation. Cause of hepatomegaly is due to the right heart failure. And the medication which is not necessary, out of the given option, I choose the anticoagulant. And what further investigation would you like to send to confirm the diagnosis? That is a echocardiography.
Can there be tenderness
Echocardiography.
or not, sir?
There will be a tenderness, yes. Okay. Next, our interesting area here, TB. Let's go to the TB. So we face a lot of TB cases, huh? Recently, we faced a huge thing in our hospital because one of our patient didn't give the history of TB, and he has been put on a general ward. And you know how many sputum positive we got? 14 sputum positive. You know, sleepless nights. Continuously, we are surveilling every person on the ward. Anyway, fine. So, TB is due to what organism, people? Let's start. TB is due to what organism?
Mycobacterium tuberculosis.
Tuberculosis.
Mycobacterium
Very
bovis.
good. Mycobacterium tuberculosis. Mycobacterium tuberculosis. What is the other name? Out of curiosity. I don't want this. What is the other name of Mycobacterium tuberculosis?
Mycobacterium bovis.
No, that is another bacteria. We have the another name. It was named after the scientist who discovered this. Any idea?
No idea.
No idea. Okay. Have you ever heard about this term called Koch bacillus?
Yes.
Robert Koch.
Robot.
Robert Koch was first discovered the Mycobacterium tuberculosis on 1882. That's why it was named after the Robert Koch. Mycobacterium tuberculosis is also called as Koch bacillus. Okay. So speaking about this
Cox TV abdomen TV11 months है ना तो
Yes. Koch is a scientist who first discovered this Mycobacterium tuberculosis bacteria in 1882. That's why wherever the Mycobacterium tuberculosis organism is there, we call that organism as Koch bacillus. Okay, we call the pots when we have the Koch spine, we have the Koch abdominal also, we have the Koch, and urinary bladder also, we have the names. We name multiple things after Koch because of the Mycobacterium tuberculosis. Okay, we have two types of TB, people. Primary TB and secondary TB. Primary TB arises with initial exposure. Okay, what type of necrosis you will see in the TB? What type of necrosis you will see in the TB? Very important MCQ.
Yes.
Anywhere you go in the world, they will ask you. Yeah. Very good. Somebody was saying the name. Go ahead, doctor.
Yes,
Say it
yes.
out.
Yes.
Caseous necrosis or caseating necrosis. Very, very good. Okay. Caseous necrosis is a type of necrosis you will see in the TB. Okay. So, which results in especially in the lower lobe of the lung, and it forms a bone complex. What complex it forms? Bone complex. Mostly they are asymptomatic. Most of the patient with the primary TB are asymptomatic. Okay, while the secondary TB is, what is that secondary TB? Is a reactivation. Okay, secondary TB is due to the reactivation when exposed to something. Whenever the patient is having immunocompromised status or old age, they will have the secondary TB. Okay, immunocompromised status means maybe the AIDS or maybe the other ones or something. Okay, basically it forms a caseating granulomas, and the patient comes to you with a fever, night sweat, productive cough with the hemoptysis, weight loss. How does the TB patient comes to you?
Fever, night
Fever,
sweat,
night
productive
sweat,
cough,
productive cough. Yes, very good. Productive
weight loss.
cough, weight loss. These are the 4 classical symptoms you will see. Very good. So in that, the patient has been, whenever you see these 4 words, immediately you have to think about, okay, he's the
TB.
guy. I'm gonna done this goddamn sputum AFB. What is this AFB?
Acid fast bacillus.
Very good. Acid fast bacilli. So whenever you see in the ER, you always think that this is the guy I wanna do that AFB. And when the AFB has been done, it will be positive. Okay, and it can able to spread into the systemic one. Yes, lumbar vertebrae, we call that as a pot. Meningitis, TB meningitis is there. Cervical lymph nodes is there. And the kidneys, what type of specific findings you will see in the kidney? What is the appearance you will see on the TB kidney? Any idea? Surgical MCQ, not my topic.
Potty kidney, potty or क्या बोलते
Putty kidney or putty
Kidney.
kidney or put kidney or however you call it.
Yes.
And similarly, what type of ureter you will stand in the TB?
Ureter.
What type of ureter finding you will find?
Post caval.
Okay. Renal TB is there, no? When the renal TB
Yes.
is there, you have the ureteral TB also. And you also have the bladder TB. Okay, what type of bladder you will see? What type of ureter you will see?
Stricture is present on
Okay.
ureter.
Okay. There is one small thing. We see either a sawtooth ureter or corkscrew ureter.
Beaded ureter.
Mainly corkscrew ureter or bearded ureter or sawtooth ureter we will see.
Yes.
And thimble bladder and putty kidney are the classical findings of a TB in the genitourinary. Okay, the named things are important for the exams. Okay, that's why I mentioned it. If not, I would have not mentioned it. Okay, coming back to the lungs, we see the
In
caseating
renal
granuloma.
TB, we can also find sterile pyuria. No?
Yes, sterile pyuria is one of the common findings. Yes. Okay. Let me move on to the question here, people. Can somebody read the question? Faster.
25 years old girl present with hemoptysis, weight loss, breathlessness, and cough. Chest X-rays show cavitary lesions on apex of the right lungs. Diagnosis is TB.
Very good. What is the gold standard for diagnosis?
Sputum examination for AFB.
Sputum for AFB. Why not PCR or chest X-ray or Monte test? Monte is a non-specific. Chest X-ray indicates the pneumonia, but we can't able to see specifically it is a TB pneumonia. And PCR is for viral. Okay, sputum is mainly for AFP. Okay, and another one is this. What is this? We call it most common side effect of ATT. Speaking about this ATT, we have that ATT. Yeah, we have that ATT. Why we are having this ATTs here? So what type of category of patients we have and what type of ATT drugs we give in each category of patients? Any idea? What are the four? We clinically categorize the patients into four categories for the TB. Okay, we clinically categorize patient into four categories for the TB. What are those categories? Who belongs to category 1 and who belongs to category 2, who belongs to category 3 and 4? Go ahead, people. Fast, fast, fast.
New case or new relapse case? Or
go ahead.
resistant ATT, isoniazid resistant.
Okay, then I don't know the standard guidelines in in Nepal, but in India they used to call that as a NTEP. The program which goes in there is so called as NTEP. Okay, in that program we have this four category of patients which belongs to this TB. What is that NTEP? National Tuberculosis Elimination Program. Okay, speaking about this NTEB, the category 1 guys usually belongs to the new cases. Who are they? Category 1 guys belongs to the new cases, while category 2 is a recurrent one, while category 3 is a MDR variety, and category 4 is a XDR variety. Okay, so here the patient is a newly diagnosed one. So she belongs to category 1. And for category 1, we have to shoot the HRZE. What are the HRZE here?
Isoniazid, rifampicin, ethambutol.
Very good. Isoniazid, rifampicin, ethambutol, and
pyrazinamide.
Pyrazinamide. Okay. So H stands for isoniazid, R stands for rifampicin, and Z stands for the pyrazinamide, and E stands for ethambutol. Very good, people. And I want to say you my first clinical question was what are the TB drugs, and I have to explain to my consultant that time all the TB drugs with their side effects. So I still remember that long ago. So he asked me, what is the why we are sending a LFTs to this ATT patients? Okay, because most of the drugs causes most of the drugs are hepatotoxic. So that's why the common side effects, as you said, it is a hepatitis. Okay, whenever the TB patient is on, you always have to start them on the, you always have to monitor their LFTs and also their I, because the ethambutol causes, here the question number 5, because the ethambutol causes. Read the question number 5 here, doctor. The ethambutol causes optic neuritis. The ethambutol causes optic neuritis. So whenever the patient is on the ethambutol, you always have to monitor his eyes. And any patient who is on the isoniazid or rifampicin or pyrazinamide, you always have to monitor their LFT because it can cause hepatitis. Okay. So speaking about that, and also most common thing we used to experience when we were working in the ICUs. When we were working in the ICUs, the most common thing we experience here is the first thing is this, what do we call it? The most common thing is the junior nurse who are not exposed to their they will always come to us and say, sir, the patient is having a hematuria. The patient is having a hematuria. The next thing you should always ask the nurses, is he on? Is he on?
Streptomycin.
ATT, because rifampicin causes orange color urine and orange discoloration of skin also. Yes or no? But often misinterpreted by the nurses as a hematuria. So they always comes to you and say you that, sir, this patient has a hematuria. I don't know why he developed it all of a sudden. Then immediately you have to ask her one question, that is she or he on the ATT? And they say yes, then you have to explain the nurse it is due to the ATT, which is the rifampicin. Okay, so here we have covered, in this situation, we have covered three things. The patient with the weight loss, hemoptysis, chronic cough. Diagnosis is patient with the hemoptysis, chronic cough, weight loss. Diagnosis is
Tuberculosis.
TB. And what is the gold standard investigation?
Sputum
Sputum
examination.
for AFB.
Yeah,
Which
this year.
ATT causes optic neuritis? Which ATT causes optic neuritis?
Ethambutol.
Ethambutol.
Very good. Ethambutol. Which one causes orange color urine?
Rifampicin.
Rifampicin. Very good. And which one causes a hepatitis?
Isoniazid.
Isoniazid.
Isoniazid. Not only isoniazid, but also we have this isoniazid, rifampicin, and also we have this what do we call it? Pyrazinamide, and all those things. Okay, so you have to remember that. And speaking about the categorization of the patient, so what are the categories of how many categories we have?
4 categories.
Four categories we have. What are they? Category 1, Category 2, Category 3, and Category 4. On the new cases comes under what category?
1.
Category 1. And recurrent cases? Category 2. And drug resistant cases comes under Category 3
and
Category 3 and 4. Okay. And out of that category, we have to give them the treatment regimen. So for Category 1 patient, what is the treatment duration and what type of drugs we will give?
6 months. 6 months.
Go ahead. HRZE, then?
For 6 months. 2 years. 4 HRZD plus 2 years.
Okay. What drug is the streptomycin or streptogramins we use as? Why we are using for the TB? Little bit curious.
Drug resistance.
I'm asking a lot of questions, sir. You're asking me a lot of questions, sir. In that particular topic, finish fast and go, sir. Yeah, I can understand.
We can also streptomycin we can also use in hepatitis, sir.
Hepatitis also, no, little bit. We avoid it, but we give it to the XDR or MDR TB.
If there is a resistance to all of the drugs, or rifampicin, isoniazid, or ethambutol, then also we can give streptomycin or not.
I can't understand. Sorry for that, doctor. My bad. Can you say it again?
Sorry, in ATT-induced hepatitis, we can also give a streptomycin or not?
We can give, but we have to see the other ones mainly. But basically, we will declare that XDR or MDR in a very rare scenario. But we can. Why not? Sometimes.
So, in the ATT-induced hepatitis, for how much time we can hold for ATT?
No, we have to hold for 2 to 3 months.
2 to 3 months. And what we
sometimes
continue
we have to hold it for 2 to 3 months, and I understand that the patient again develops a multi-drug resistant. Again, what we will do, sir. But basically, when the hepatitis is happening, we will first, where the patient used to be in a 4 therapy or 2 therapy. Okay. So how we approach it clinically is, whenever the patient has been developed this hepatitis, we try to skip one by one drug. So we watch which drug is exactly causing the hepatitis. Okay, we have 3 drugs, no? Pyrazinamide is there, rifampicin is there, ethambutol is there. Yes, so on alternate days we will skip one by one, and within a week we will skip all of them except ethambutol. Okay, we will run the ethambutol in a sideways, and then we will start reinitiating the drugs after 2 weeks one by one. Okay, we develop this what do we call it, drug resistance. Then we go for the higher drugs. Okay, basically that kind of things are very very rare.
I have seen
Anyways.
one case, sir. So that's why I'm asking.
Share,
I have
share me
seen
the
one.
share me the knowledge. I am all open ears for the knowledge.
I have seen one case, and so I have asked.
Okay, so you have seen a cases with this
APT-induced
ATT-induced hepatitis, huh?
Yes, yes.
Very nice, very nice. We used to see it back when I was in India for sometimes, but now it is okay. Now we are seeing very less, and even here the regimen is totally different, and all those things are different.
His
Anyways,
bilirubin
fine.
got survived, sir, and SGPT,
Oh my
SGOT
God.
also.
Oh my
After
God. Oh my God. When
after 3 to 4 weeks, he develops jaundice, sir.
in those things you have to stop it abruptly. You have to stop the thing abruptly for that. Anyways, fine. So again, fever cough for a month. 45-year-old worker came to hospital with a history of fever and a cough for a month. Again, this is a very small, fast one. You can tell me what are the fast ones? You can easily get it fast. Can somebody read the question and somebody answer me fast? Because you guys have already answered me this question. So I don't want. I want to move on to next. So answer me. Yeah, go ahead, people.
45 years old worker came to hospital with history of fever and cough for a month. What is the most probable diagnosis?
Diagnosis.
Pulmonary TB.
Yes. Yes. And how will you collect
Pulmonary.
the sample for sputum? Morning sample is a optimal sample.
Yes,
Okay.
sir.
Dual sample we take, but morning sample is the optimal sample. Next, go ahead. Next.
What
What is
investigation
not
is
done?
not done? Widal test.
Not done.
Widal test.
Why?
Why? Because
Just for
chest X-ray can
STDs. Okay. Chest
thermometer.
X-ray we will do, Monta we will do, and the sputum also we will do. You said it with the option of neglection, huh? Okay. What is the treatment for it?
Category 1.
What category? Yeah, because she's a new one. And
One
red color urine.
is due to rifampicin.
Very good. We already discussed that. Okay. So shall I move on to the next? Next is an important area here, people. Cystic fibrosis. Let's talk about the cystic fibrosis. So what is a cystic fibrosis, people? Tell me.
Celiac disturbance, sir.
Okay, mucociliary dysfunction, I will rather say. Very good. Okay, what are the things that can result in the cystic fibrosis? It is due to the what gene mutation?
Sodium potassium.
There is a gene. There is a gene mutation occurs in the cystic fibrosis. What is the gene? Anybody? Because it is an autosomal recessive, no? You remember cystic fibrosis transmembrane conductance regulator gene, CFTR gene mutation.
CFTR
What
gene,
gene
yes.
mutation? What gene mutation? CFTR gene mutation we will be there, which code for the cyclic AMP chloride channel in the secretory epithelium. So now it is impaired. So whenever there is the secretory epithelium is having this mucus impairment, the what will be the viscosity of the secretions?
Viscosity decrease,
What will
sir.
be the viscosity of the secretions? Viscosity of the secretions will rise or fall. The thinning agent is absent here. The thinning agent is absent means the secretion viscosity will rise, especially in the
Rise.
lungs or pancreas and all. Okay, whenever the lungs it is having a high thickened secretion, automatically airways will be obstructed
Blockage.
by that secretion and obviously result in the obstructive lung disease. Okay, so there is a defective chloride secretion which is due to the gene mutation, and there is an increased sodium resorption across the airway epithelium. Okay, when there is a low sodium, when there is a low absence of a chloride secretion, and there is a low sodium in the epithelium, because all of them are reabsorbed, it will cause the bacteria to colonize. So CFTR, cystic fibrosis patient are prone to more infections. Where is the CFTR gene located? Another important MCQ. Just discussing this out of curiosity, because that is a question. Where is the CFTR gene located?
Chromosome 7. Chromosome 7.
Yes, I'm writing. The screen is there. Chromosome 7 long arm. Okay, chromosome 7 long arm. Okay, how does the patient presents to you with the cystic fibrosis, people? It is a multi-system disorder, right? When it is a multi-system disorder, the patient will present with the opacification of the nasal sinus. Very, 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 very important, because that occurs in the pan CF patients. Okay, pan opacification of nasal sinus. Clinical features are pan opacification of nasal sinus. Of nasal sinus. Okay, number 1. And number 2, GAT malabsorption. Why GAT malabsorption? Because lack of fluid. Mucus is lacking, no? So GAT malabsorption is there. When GAT malabsorption is there, what about the fat? Will they get absorbed? No. You will get a fatty stools, constipation. Yes or no? Fatty stools, constipation, gallstones, all the things. Okay, and what about the chest infections? Recurrent chest infection. And most of the patients don't thrive at all, so they will die. Okay, failure to thrive. Okay, so speaking about that, any patient, I rather say, we used to, how does we peculiarize cystic fibrosis? Why we need to run the test for cystic fibrosis is, any patient who is coming to you with the constipation and the recurrent lung infections from the childhood, when you are trying to see what is exactly going on, immediately you try to see there is a gallstone by the age of 8 to 9. Most people don't survive till there, but when you see the young adults with the gallstones and fatty liver, you always have to rule out the cystic fibrosis. Okay, and apart from that, you will also see the meconium ileus in this patient. So these are the characteristic clinical features of the cystic fibrosis, because we can't able to identify which one is a cystic fibrosis symptoms, because it is occurring in the every organ, so we cannot specify them in the lung itself. Okay, but lungs, they will have a higher chance of recurrent infection. So treating an acute infection is always a challenge in the cystic fibrosis patient, people. Okay, what type of organism we will see mostly colonize in the cystic fibrosis patient? What is the most common organisms which are colonizing in the patient? You know, we have talked about the clinical features. Now we see these patients are more prone to the recurrent chest infection. That means bacteria is more colonizing in the lungs or any other area. Okay, what are the common bacteria we will see in the cystic fibrosis patient which has been colonized there? Any idea?
Staph aureus.
Very good. And then?
Mycobacterium.
Very good.
Influenza virus.
Okay. Influenza virus is not there. Haemophilus influenza will be colonizing. Okay. Okay, let me write it. So basically, the organism which is colonizing in the cystic fibrosis patient based on the age only. So in a young patients, this is important. In a young patients, you can expect a staphylococcus, Staphylococcus aureus, Staph aureus. You can use it. Okay, after the Staph aureus in a young patients or teenagers, your children's teenager is different. In the children or young patients, you will see the Staph aureus is the most common, or Haemophilus influenza. Haemophilus influenza. Okay, but in the case of the teenager or old patient, you will see the Pseudomonas aeruginosa. Pseudomonas aeruginosa. Okay, then apart from that, you see the aspergillus, and you will see the Burkholderia and Mycobacterium. Burkholderia cepaceae especially. Cepaceae. And you will see the MTP, Mycobacterium tuberculosis. So most common organism in the young children is Staphylococcus. In the adults, it is very important MCQ. Even wherever you go and write an exams in the pulmonary cystic fibrosis, you will always being asked this question: what is the most common organism occurs in the young children and also in the adult? In the adult, they will also ask you the treatment option. It is an inhaled tobramycin. In adult, most common organism is Pseudomonas aeruginosa, while in the children it is Staphylococcus aureus. And Pseudomonas aeruginosa with the adult cystic fibrosis patient with Pseudomonas infection, you have to give the inhaled tobramycin. You have to give the inhaled tobramycin. Okay. So gene defect CFTR, pan opacification of nasal sinus, malabsorption, recurrent chest infection, gallstone, and meconium ileus, failure to thrive are the common features. And apart from that, you will see here pancreatic insufficiency, rectal prolapse, infertility, subfertility. Sir, you didn't say me, don't say that. You will see. And remember one important thing: any patient with the FEV1 less than 60%, they may have the viability of pregnancy, the woman with the CF especially. Okay, and the organism which colonize in the CF patients, in the young patient Staphylococcus, and in the old patient it is a Pseudomonas. And what is the diagnosis here, people? What is the diagnosis? Can you able to see here, or you want me to erase it? Can I erase it? If you write it, I will erase it, no problem. And I will write the diagnosis here. May I? May I erase it, people? May I erase it?
Yes.
Okay. Okay, let me go ahead here. So diagnosis of cystic fibrosis. What is the diagnosis? Mainly it reveals on the sweat test. Sweat test with the sweat chloride more than 60 mol per liter. Sweat Cl should be more than 60 mol per liter. Okay, more than 60 mol per liter. Okay, how do you conduct the sweat test? Any idea? Any idea how do you conduct the sweat test? Fast, people. I have to move. We are talking lot and lot. Concepts and their cases. Oh, man. So tell me, cystic fibrosis and sweat test. How do you perform the sweat test? We use a pilocarpine. Okay. So we use the pilocarpine and we passes a 3 mA current which carries the pilocarpine in the skin of the forearm. Okay, what is this pilocarpine? What is the mechanism of action of pilocarpine? It is a cholinergic agonist or antagonist? Come on, people. Pilocarpine mechanism of action. Cholinergic agonist or antagonist?
Agonist.
Cholinergic agonist. Okay, so what is the main function of cholinergic parasympathetic nervous system in the skin? It triggers the excessive secretions, excessive exogland secretion. Right. Now we pass as a current 3 milliampere current of pilocarpine, which carries the pilocarpine in the skin of the forearm, and we stimulate the local sweating. Then the arm is washed with the distilled water, and the sweat is collected on a filter paper or a gauze. Okay. When we collect that filter paper or when we collect that sweat, we usually collect it for 30 to 60 minutes. And then the filter paper is removed, weighed, and then they will be eluted in a distilled water. Okay, so we pass the pilocarpine skin, wash with the distilled water, collect the sweat for 30 to 60 minutes. Paper will be removed, weighed, and eluted in the distilled water, and at least 50 mg and preferably 100 mg of sweat should be collected by the reliable result. Okay, if it is more than 60 mol per liter of chloride is there, that means technically the patient is diagnosed with the CF. Okay, technically the patient diagnosed with the CF. Normally, the patient will have a very less chloride in the sweat. Okay, even in the healthy adults, when they are too much exercising, the sweat chloride values will increase slightly. But 60 mol per liter, it technically indicates CF. Okay, can we get the false negative also? Can we get a false negative also? Yes, patient with the nephrotic syndrome, we get a false negative sweat test. Okay, you have to understand that. Okay, then we have a diagnosis. We have already talked to you about the diagnosis. Basically, it is solely on the clinical and especially pulmonary and gastrointestinal manifestations. Okay, speaking about the management, what are the management protocol for the cystic fibrosis people? What are the management protocol? Regular chest physio, high calorie diet, including high fat intake. Okay, high calorie diet. Okay, and whenever you see that a patient is having usually we recommend high fat intake, but patient have a steatoria, we have to take a low fat intake. Okay, vitamin D supplements. Okay, pancreatic enzyme supplements with the meals. Pancreatic enzyme supplements with the meals. NAC you will give N-acetylcysteine because it will thin the mucus, and you will have a heart or lung transplant is a source to control the mucus secretions. Lung transplant is also one of the characteristics. Gene therapy is there, but we don't use the gene therapy because it is too much. You know, in the UK, they used to cost around like more than 600,000 pounds. Nobody will do that. NHS will not fund that. Anyways, fine. This is a management protocol for the cystic fibrosis. Okay, patient basically dies early age, very rarely. Okay, they will survive. When they survive, they will have they have to manage lifelong with the things. Okay, shall we move on to the case? Now, somebody read the case. Somebody read the case here. Fast, people. Go ahead. Talk. Read the case, people. Faster. Read the case. Faster. Okay. A 38-year-old male presents to the medicine OPD with a complaint of cough for 3 months with a copious sputum production. Copious sputum production, cough without fever and clubbing. Finger clubbing is noted on her fingernails. What are the common differential diagnoses for clubbing of nails? Pulmonary, lung cancer or abscess, pulmonary fibrosis, pulmonary TB. For a heart, it will be a congenital heart disease, congestive heart failure, and infective endocarditis. Hematologically, CML, thalassemia, Graves' disease, IBS, liver cirrhosis, GA neoplasm, hypervitaminosis A, HIV infection. All of them causes a clubbing of a nail. Okay, here it is due to the fibrosis that is secondary to the cystic fibrosis. Okay, so most common likely diagnosis here is a bronchiectasis because of the cystic fibrosis. He complains of salty sweat which is produced in excessive amount. What is the most likely cause? Which is due to the cystic fibrosis here. Most common pathogen causing pulmonary infection in the case of adult is, what is the organism? We discussed, fast people. We discussed what is the organism here in the adult people.
Coccus. Staphylococcus.
No, Staphylococcus aureus is for the young people. For adult, Pseudomonas. And the treatment of choices, I also told you treatment of choice, but I didn't write. I want to know who paid attention. Now tell me, what is the treatment of choice, people?
Chest physio.
Inhaled tobramycin. I told you, inhaled tobramycin. Okay, what is the cutoff value for sweat chloride? It's that strongly suggests cystic fibrosis.
Greater than 60.
More than 60, yes. The cause of thick pancreatic secretion in cystic fibrosis is due to
Failure due to clear mucin due to epithelial dysfunction. No, sir.
defect in chloride channel, which is leading to water reabsorption, or defect in sodium channel leading to water reabsorption, or mucus failure to clear due to the epithelial dysfunction. Which one here?
Defect in chloride channel due to water reabsorption.
Defect in chloride channel due to water reabsorption. Exactly. That's what we have told. Because it will act on the CAMP chloride channel of the mucous epithelium. Yes, we have done with the cystic fibrosis people. So next is a pulmonary embolism. I think the time is too much, so we will revise it first a little bit. So speaking about it, I want to ask you the questions from the previous topics which we have discussed today. So we will discuss that for 5 to 10 minutes and we wrap it up. Okay. So first thing, pneumonia, lobar pneumonia, causative organism. Two organism I told. Yeah, Klebsiella and Strep pneumo. Okay, very good. Speaking about the Klebsiella, what type of jelly sputum you will see?
Crust jelly.
Current jelly sputum you will see. Current jelly sputum you will see.
Jelly.
Okay. What organism causes super infection? Staphylococcus aureus causes super infection. Okay. And consumption of paraffin causes chemical pneumonitis. True or false?
False.
False. It causes a lipid pneumonia. Very good. And any patient with the COPD and altered sensorium. Altered sensorium is due to what?
CO2. Hypercarbia.
Okay.
Hypercarbia or CO2 retention. Both are same. CO2 retention I rather prefer. Okay. Anyway, fine. A patient with a car pulmonale, what type of murmur you will hear?
Pansystolic.
Loud P2. That is a pansystolic with a prominent S2. Okay, very good. And what is the optimal test you write for this patient? Investigation of choice for this patient.
ABG.
Echo. We quantify the edema.
Core pulmonary echo.
Yeah. Echo. Gold standard diagnosis for the pulmonary TB.
Sputum for AFB.
Gold standard diagnosis for pulmonary
PCR.
TB.
PCR.
Sputum for AFB.
PCR.
Sputum AFB. Sputum AFB we do. Okay. How will you collect the sample for the sputum? Morning or evening?
If there is a gene export and AFB, which we should write, sir? If option are AFB, sputum for AFB and gene export, which one is the correct for gold standard investigation?
We go for gene expert because nowadays gene expert is giving a very fast results. We go for gene expert, but our standard is sputum for AFB.
Standard?
Standard is sputum for AFB, but we go for gene expert for the rapid thing. And technically, Nepal guidelines might have updated. Then you have to go for gene expert. Okay, if not, I rather choose standard as sputum for AFB. Okay, because I follow nice guidelines and I teach for various exams. Most of them follow sputum for AFB. Okay. And what about the cutoff value for sweat chloride test we do for cystic fibrosis?
Greater than 60 millimole chloride.
Greater than 60. Very good. What is the most common organism associated with the cystic fibrosis young patient?
Young Staphylococcus aureus.
Staphylococcus aureus. While in the adult?
Adult is Pseudomonas.
Pseudomonas aeruginosa. Here I have the small question. Pseudomonas will have that special toxin. Okay. What is that toxin which we have this acting on the ribosomes? What toxin of Pseudomonas which act on the ribosomes? Microbiology.
Exotoxin.
Exotoxin A or exotoxin alone?
A.
Exotoxin A act on ribosome. How? It inhibits a specific thing. What was that? Elongation factor 2. Okay. Elongation factor 2 inhibition is mediated by Pseudomonas exotoxin A. Okay. What is the other toxin which inhibits the elongation factor 2? What are the other toxins which inhibits elongation factor 2?
Exotoxin U. Exotoxin U or S, sir.
Okay. Okay. Technically, diphtheria toxin. Okay. And exotoxin A. Okay. Colix toxin from Vibrio cholerae. And we have this, what do we call it? These two. Apart from that, ribosomes, we have the EHEC, which causes a Shiga-like toxin and a Shiga toxin. I don't remember, man. Microbiology I studied almost 10, 12 years back. So I don't remember most of them. Okay, anyway. So we are going to wrap up the session. So how do you feel the session? Was it informative? You guys liked it? I was going a little slowly, but technically I was trying to run with the cases and all, but I prefer that this method will capture you more concepts than the other things. That's why I was slowing down on the doing in a conceptual way. So you guys understood the things, you guys felt it easy, the CSQ, how to approach the case questions and what type of things. You guys understood it, or you guys feeling like, no, we already know the stuff kind of things? You can help me with that. So shall we wrap up the sessions? If it's okay.
Yes, sir. Thank you, sir. It was really
Thank you, sir.
Thank you, doctor. Thank you, doctor, so much. And I'm going to close these things. Okay. So thank you so much, everybody, and have a nice night. Hopefully seeing you in the further sessions. Thank you so much.
Thank you, sir.
Yeah.
Thank you.
Thank you, sir.